I want to welcome everybody this evening who's joining us. We're very grateful to have you here, but we're also extremely privileged to have a fantastic panel tonight to talk about telehealth and allied health and the allied health professions that have been using it. So I just want to say kia ora, and just welcome to all of you. I'm Becky George. I am an occupational therapist by background. I'm a passionate believer in digital health as an enabler for our therapy and allied health professions. And I chair the National Allied Health Informatics Group and currently am chair of the HINS board. I'm going to go round our panel that we're really pleased to have this evening, and I'm going to ask them to introduce themselves and give a wee bit of context about who they are, the role that they play, and the context in which they serve at the moment. So Pip, I'm going to start with you. Welcome.
Kia ora everybody, I'm Pip Zammit and I work for the Northland District Health Board. My background is dental therapy. And currently I am the Director of Scientific, Technical and Allied Health in Northland, and I'm also the Service Manager for Oral Health.
Welcome. Thank you. Miranda, welcome.
Tēnā tātou katoa, ko Miranda Buhler tōku ingoa. I'm a physiotherapist and a hand therapist in Dunedin, at Dunedin Hospital, part of Southern District Health Board. And my role work-wise is primarily clinical. Through the telehealth experience, I was part of a telehealth leadership group as a clinical champion for that, and really neat to be able to build on some previous experience and draw on some amazing expertise within DHB to look at what could be delivered in those circumstances. So thank you very much for having me along.
Great to have you. Amy, welcome.
Thank you. So I'm Amy Dakers. I'm a physiotherapist by background, mainly in paediatrics, and I'm currently the clinical informatics lead for primary and community at the WDHB. And alongside that, a part of my role is that I'm leading the rollout of the telehealth solution that we've created across the DHB as well.
Thank you, Amy. Aoife, welcome.
Kia ora koutou. My name is Aoife O'Reilly. I'm a speech language therapist and I'm the operational manager for the speech language therapy team at Wellington Hospital within Capital and Coast DHB. So CCDHB operates two hospitals. We've got Wellington Regional Hospital and Keniparu Hospital in Porirua, as well as the Kapiti Health Centre in Paraparaumu. So geographically, we cover quite a long area. And so we have been especially delighted by the rapid advances in telehealth over the past few months. So the speech language therapy team is part of our ORA services, which covers older persons rehab and allied health. And that's a group of services that work across inpatient, outpatient and community environments. And it's got two arms. We've got health of the older person and rehab as the other arm. So my team specifically works in Wellington Hospital across adults and paediatrics in both inpatient and outpatient settings. So working with a range of patients with both communication and swallowing and feeding disorders, right from infant up to older adult. That's me.
Great, awesome. Thank you for joining us this evening. And finally, we have Sharon. Now, we've been having a few issues for Sharon, poor woman, with her connection. So she may take herself off video from time to time, just to ensure that we don't actually get a break from her communication. So Sharon, welcome.
Tēnā koutou everyone. Apologies for my very weak Wi-Fi. So my name's Sharon Russell. I'm the Associate Director of Allied Health Scientific and Technical Professions at Waitemata DHB. And for those of you who aren't aware, there's 43 professions that sit within allied health and the scientific and technical professions realm. So there's quite a few of us. I'm also, in my spare time, the professional and clinical lead for the physiotherapy team, but at the moment I have somebody who's acting in that role for me. So at Waitemata DHB we have 3 sites, and allied health work across all those sites. We've got the child, women and family, we've got mental health, adults obviously. So we have a rather large area geographically that we cover. So telehealth and digital health is something that we've been very passionate about. and it's great to be on this panel, so thank you for the invite.
Great. Oh, thanks for coming and joining us. So as Sharon mentioned, allied health is an umbrella term that allows us to bring together numerous professions, and at the moment in New Zealand it's about 43 different professions that come together to celebrate the diversity that being health professionals can be. And so we range broadly, and it's allied health scientific and technical most of the time in terms of portfolios that are held by our strategic leaders. And so we can cover, and as Pip's demonstrated, dental therapy through to radiographers, through to music therapists, and social workers, dietitians, you name it, acupuncturists, osteopaths, chiropractors. So we've got a diverse community across New Zealand that is represented under that umbrella. And we actually have a significant proportion of that workforce working in the private sector as well. So over this year, we've encountered numerous issues concerning the provision of healthcare during the COVID pandemic and since it. And a number of the things that I want to raise this evening are really about the use of telehealth across those issues. They have been many issues in common with most of the clinicians trying to practice through those times. But essentially what I really want to highlight this evening in the panel and the questions that we're posing is very much around the issues for allied health, and the tension that we've tried to deal with between prevention and protection of our population and the health and well-being of our population, and how have we been able to balance that through the use of telehealth, both its benefits and its limitations. And so what are we going to be looking ahead in the future is what we'll come to finally at the end of our webinar. So I'm going to kick off my first question. We've talked a lot in the webinars and forums this year about clinical engagement with telehealth. What's the process been like for the allied health services that you serve with at the moment? And I'm going to start with Aoife.
Thanks, Becky. I guess our allied health services were actually very well positioned at the start of March, in the sense that we had launched telehealth guidelines for allied health in October 2019 in somewhat of a preemptive move. So we did feel somewhat ahead of the curve when it became a routine way of practice with the introduction of the COVID-19 restrictions. And this launch was really well promoted. There was guidelines and information circulated. We had telehealth champions appointed to each allied health discipline, which really helped with engagement and bringing telehealth from like a strategic level to a practical level. We had drop-in sessions arranged for clinicians to come in where they could ask questions of the project coordinators and troubleshoot any issues they've been experiencing and practice using applications for telehealth. And that process had very good feedback from the clinicians. And then there was like a quick reference guide for clinicians that was also circulated, and patient information handouts, which were prepared as part of this early launch. So that served us in really good stead when it came to using telehealth as a more routine way of practice. And kind of with the launch as well, clinicians were asked to complete a short monthly report about their experience with telehealth, kind of feeding back on how it was being used, how it's worked well, what the issues or concerns were, any barriers, kind of patient stories about the use of telehealth. And then those responses were used to inform education needs and policy and promote telehealth to other teams. And that seemed to work really well. The patient stories particularly being powerful in kind of onboarding other people into recognizing the uses of telehealth and how it could apply within their profession.
Thank you. And so just to pick up on that's fantastic to get those patient stories so early and so relative in terms of the rollout and the training and the ability to have the recognition going across. Did you only share those patient stories internally, or were you able to actually share them wider? Was it beyond allied health or just in allied health?
Yeah, it went beyond allied health. Yeah, at a higher organizational level, it was fed back at kind of governance meetings, and so it was made known beyond just allied health.
Great, wonderful. Pip, how are you doing?
Yeah, hi. Well, we're doing quite well now. Well, it was a very steep learning curve for us when COVID hit, and there were sort of pockets of telehealth that were happening across the organisation, but it wasn't something that everybody routinely did. But allied health professionals are so flexible, and so quick to pick things up that once we had sorted out some guidelines and sorted out what patient groups we could actually use telehealth with over that period of time, they just went with it. What we did find in Northland is that in many places we haven't got any internet connections. We have got a number of people that also don't have access to any type of mobile device. So that was a little bit challenging in the beginning, just trying to work out which patient groups did have access to telehealth, and then how are we going to support those patients that didn't have telehealth in Northland. Yeah, so it was a steep learning curve, but as I said, we got there, and I think it was really, we've had some great patient stories that have come back, particularly from our older population, and that they learned something so amazingly new and could show all their whānau about how clever they were. So that was, we've had some really cool stuff that's happened like that in Northland, but we've still got lots of work to do up here.
Is there anything currently going on about the equity of access?
Yes, there's lots going on about equity of access. So that is something that we are looking really closely at. So if patients haven't got access to internet or a device in their own home, how can we facilitate patients to get to a marae or another community facility whereby we can provide telehealth clinics in that facility or that environment? So
yeah, great. We might dig into that a wee bit more later too, so that's awesome. Great to know. Miranda, how about you?
Our move into telehealth was a very steep jump, a bit like PIP. We didn't have a lot of allied health specific guidelines to go by. We have a telehealth coordinator who's been well embedded throughout the DHB, and there are pockets of people who'd had good relationships and experience with that. But allied health had limited access to devices themselves, so in terms of computers, 6 in a department of 18 staff, so getting laptops out to staff, not many staff had mobile phones, and then headsets. So getting all of that equipment in place, where there were very proactive managers, that happened quickly and helped a lot. In terms of processes and so on, so there was very rapid review of literature, guidelines available to assemble what a feasible body of information that people could digest quickly and put into practice. So it was a very practical set of information. Sorting out platforms to use. So across the DHB, there'd been a number. There'd been Link off the back of previous programs, video, Zoom, and in the end settling with Microsoft Teams because it had some superior privacy and data security features. So being able to get that in and for everyone to learn one platform rather than having to learn 3 in a row. And then, connecting with the resources we needed to develop information for patients, to make it known that the service was available, how they could engage with it, and then processes to set up appointments, to make good documentation, to gather the data, and bringing admin into play to make it a feasible process. And I think that that's a really key part of the future, to have it embedded and sustainable going forward. And, clinicians were very patient-centered, and I think that's one of the amazing experiences of this process was turning everything you do upside down so that it worked for the patients, not having to stick with what's the structure of the service to date. And I think people enjoyed that, the patients appreciated it, and that in itself was a really valuable learning. So yeah, really good engagement. A lot went on very quickly, and our district equally, huge geography. I think Southern is the largest of all the districts with the smallest kind of population, and COVID essentially made everyone physically distanced, and so we had to be far more responsive to that, and again, a good learning.
Great. Miranda, did you have any pockets where telehealth was already being used, sort of within the region at all? Were they able to link in and support with that?
So there had been some with the coordinator. A little bit of the pain clinic work had some dabblings. With hand therapy, we'd had some dabblings. There'd been some work with the dietitians, pediatric diabetes. The consultants and the diabetic clinicians had some involvement. But making the leap from some specific smaller platforms and condition-specific processes to a DHB-wide approach that was going to work for everyone, that could be implemented everywhere, so everyone knew that what they were doing was, good quality and safe and secure. What was a big change to that.
Yeah. No, thank you for that.
Built on it.
Yeah, it's an important thing to highlight, isn't it? That particular gap in terms of the scaling.
Yep, making it scalable.
Yeah. Absolutely. So Amy, that's probably a good segue into you, knowing a wee bit myself around your context. So Amy, why don't you tell us how it's going for you?
Absolutely. So similar to Pip and Miranda, it's been a very steep learning curve for the Whanganui DHB. So there were some pockets of telehealth being used within the DHB, but the majority over telephone conversations and triaging and along those lines. So clinicians very comfortable with the use of the telephone in the telehealth space, but not necessarily the video conferencing side of things. So over COVID, we very quickly pieced together a solution similar to Miranda through Microsoft Teams, which links in with our admin staff and also, our booking system, Webpass. So we have a fantastic technical solution, but the journey that we're on now is bringing the clinicians into that and along the journey with us. So moving towards going into the services and asking them how telehealth fits into their service and how it can best serve them and their patients, and creating an internal energy and passion around telehealth and how they can use it moving forward. So it's two-pronged. It's how it fits into the service and how the solution best serves them, creating flows that suits best, and also for clinicians deciding how they want to use telehealth and engage with it moving forward as a professional. So very much in the process, we're slowly getting more buy-in and we'll just keep chipping away. It's going well so far.
Cool. Thank you, Amy. Sharon, how about you?
Yeah, so we were doing telehealth a while ago before COVID. So we'd got a trial going on in a lymphedema service, and that was going really well. And we did some really great benchmarking around reducing our wait time and our wait lists. So that was fabulous. One of the problems that we did have was getting hardware and getting the laptops and the headsets for that. But because it was just a single clinician, we were able to do it. And then COVID hit. And I like to say COVID is the gift that kept on giving in those initial phases, because all of a sudden we had access to a lot of IT. So we had laptops that were able to be used in the outpatient settings, in the community settings. A lot of the clinicians, particularly in the outpatient for physiotherapy and for the dietitians, embraced the use of telehealth. Even some of our older, more set in their ways clinicians really embraced it and enjoyed using telehealth. They found that there was a place for telehealth within their practice, so that was great to hear. The community teams did a lot of the telephone calls, a lot of the triaging. Some of them would use video conferencing, but they were more keen on staying with the telephone. They felt more comfortable with that. And we allowed that and embraced what they could do, because at that point in time, just having any patient contact was necessary. But we've moved on into the second phase, whereas people have just continued with it. And we've been very fortunate that we've now got inpatient teams that are using telehealth for some of our pre-op work. So particularly for our patients who are having to have Whipples procedures, and they have to come from Northland. We're doing all of the pre-op work via telehealth, and Waitemata is very fortunate in that we have something which we call the Peace Pod, which is TARDIS, and it allows us to have like a soundproof room, if you like, and it's got the computer and everything set up. So we do a lot of the work out of that space in allied health. And the inpatients are using that as well for SLT when they do have to do some travelling. So we've really started to embrace the telehealth. We've got policies that have been written from an IDT process that's including the nursing, that's including mental health. We've got the psychologists around it as well. So we've got a very good joined up workforce working with telehealth within Waitemata at the moment.
Great. Oh, great to hear. And it's really interesting. I'm just going to pick up and panel, I'd love you just to chip in. So I'm not necessarily going to ask now. I just want you guys to chip in. So one of the things that you've picked up on there is obviously with that Whipple service, has that exceeded your expectations? Has that kind of, I'm looking for surprises, because I think there are probably pockets where things have kind of taken off that have been a bit sort of taken you by surprise. And I'm just intrigued if that has occurred for you.
Definitely from our aspect, we've done a lot of group work. So we started with some pelvic health group work, which we talked about at HINS last year. But we've also got pulmonary rehab, which we're using telehealth for now. And the patient feedback that we get from that is just amazing. They love the fact that they don't have to come into clinic, that they can see every member of the class together from the comfort of their own homes. So that was something that we weren't sure was going to work, but the clinicians have embraced it, and the patient feedback that we're getting from that is really good. SLT assessments as well is really great to do over the telehealth aspect as well. So our SLT group are really embracing it in the community because they're not having to do that travel. So really great things that we didn't think we would get, but we've really started to excel in those areas.
That's fantastic. To hear about the efficacy of group interaction is wonderful, because I'm not sure we've been able to emphasize that much. And I think allied health sit in a specific place with that, where, you know, allied health scientific and technical professions can utilize telehealth and, you know, and demonstrate that. So anyone else got any surprises that have been really great for them?
I think across the country, really, from what I've heard about physiotherapists, there has been great engagement from physiotherapists themselves and from patients as well. And other staff are often surprised to hear that, because physiotherapy is such a hands-on professional practice, and it does entail a lot of manual techniques for assessment and treatment, and that still stands. But I think what has come to the fore is the importance of communication and the huge part that plays in good quality assessment and effective management. And video conferencing in particular, it does enable you, once you overcome the initial perhaps unfamiliarity, the technical hitches, if you can get rid of those distractions, then the video conferencing is a fantastic communication tool, and you're very close, you're focused. Sometimes people found consultations would be a little bit shorter, but potentially that is part of, you know, the effectiveness of the communication that could take place. And the visual aspect of the video conferencing does enable some of the physical assessment to take place as well. So I think, you know, that was a little surprising to many people. Nevertheless, both patients, clinicians, very eager to have their hands back on again, you know, as soon as possible. And so I think there'll be slow learnings as to how that fits, and particularly as more evidence comes in to show us that, you know, this is an effective mode for delivering care. Will reassure both clinicians and patients to, you know, it's worth pursuing and spending the time with.
Yeah. Oh, Miranda, that's great to hear, because often so many assumptions are made about hands-on clinical contact requirements that in fact what we've been able to do is possibly be, you know, thrown into an exposure that challenges that. And it's been great to hear that positive feedback. Absolutely. Anyone else?
We've had a couple of kind of outside of the box kind of surprises with telehealth as well. So I'm thinking in particular of kind of zooming other professionals into a consult. So for example, we've zoomed like sign language interpreters into a session to assist with interpretation. There was one particular example where there was concern during a home visit that a patient had an extension of their stroke. So the neurologist was zoomed in to the house and they assessed the patient through the physiotherapist who was in the house, and was able to ascertain like management plan going forward, make a call as to whether there was any suspicion that there'd been an extension of the stroke. So that was like a really cool way of seeing that in action. And some other kind of like cross-discipline use as well. So like in the home environment, zooming like OTs in to try and solve any equipment problems, come up with equipment solutions, and kind of limiting the number of people in the room and the time of the clinicians involved in travel, but still being able to get that quality assessment.
Great examples. Great to hear about the interprofessional working and the opportunities in essence around that. So that's really good. I think it's really key to pick up on some of these things as well. So around those surprises and around the benefits and opportunities, we're obviously also coming up against the barriers and limitations of it too. And we're hearing, that theme of protection and prevention versus health and well-being. There are also the technical limitations. So we might say that there are limitations of physical distance, but there are also some technical limitations that are coming and cropping up, common to many, certainly not in isolation to allied health, scientific and technical. So we've often talked about common barriers, but I'd really like to understand, and we've got a few questions here around that, but we really like to understand what are the difficulties and what are the barriers that present themselves to allied health, and possibly are a wee bit more specific to allied health, scientific and technical, in terms of how they operate and in terms of how they work. So Pip, I'm wondering if you've got anything you want to kick us off with on that.
Yeah, probably just following on what I said before. So, and I think it was Amy that alluded to it as well, is that accessing all the equipment to start with was quite a challenge across the DHB. And so, we're still in that phase of trying to get enough mobile devices, etc., where allied health professionals have access to some sort of telehealth facility always. So during COVID, yes, we did ramp it up and we did have access to that, but it seems to be that we don't have quite as much access now for whatever reason. So that is a challenge. And I think the biggest challenge for our patients was not actually having a resource available that we could actually share with our patients to get them to understand how they could actually link into a telehealth session. So there's quite a bit more work that we need to do in that space. And it's almost like a full resource that we need to have attached to some of the allied health professions that's actually working alongside patients to help them understand how to communicate via telehealth. And then, as I alluded to before, of course, trying to find other ways in which people can actually get to another facility so that they have actually got access to telehealth if that's the way that they wish to proceed. Sorry.
No, it's all right. So what are some of those ways that you believe that as clinicians present sort of some of the challenges of relating to, often it's, I think what I'm getting at is that, often when we would like to put our hands on someone to either move them or to facilitate them in doing something, we can't when we're using telehealth. Is it a matter of communication and training and eliciting reactions? What is it that you think is around that?
Yeah, I think it is. I mean, I think it's absolute total engagement with the patient. We need to understand from the patient what they would like. And telehealth for many is not what they want. So we do have to understand that and take the patient's perspective on, how they want to proceed forward. For some, though, we found it quite interesting over the COVID time, in that, yes, we went through the telehealth phase and we were all telehealth. As soon as the alerts changed, all of a sudden everybody wanted to come into clinics. And I think it's probably just a little bit of a blip, and that many of these people hadn't had well, they probably hadn't actually seen anybody for quite a long period of time, let alone talk to somebody. So we had many people congregating in waiting rooms, having long conversations with each other because they'd been in lockdown and hadn't actually had any social interactions. So that was interesting. So I think it is just a blip. I think it was just, yay, we're out of here, we're able to drive around and we can get to a hospital and have an appointment. But I think going forward, many of those people will start to understand, rather than having to travel 2.5, 3 hours, drive to a hospital, that there's another way that we can do this. So.
Yeah, no, absolutely. And anybody else in terms of barriers that are specific that they've seen cropping up?
On a technical side, for physical assessments, just having the right information for patients about where to put their device. And for example, having some good robust furniture nearby for balance assessments and things like that. So there's some good tip sheets and some of the resources. We've found things we could put in there that clinicians could just prompt themselves with. And I think there's a lot of work going on around that. And at the University of Otago, there is a postdoc researcher looking at neurological assessments by telehealth. What delivers a safe, high quality assessment. So that evidence base to that practice as well. Yeah, I think just having ways of going through and delivering, the right prompts to elicit what you need there. And I think that's specific to allied health. You don't always hear those extra things in the training delivered to other professions.
Yeah. Good point about the positioning and the camera and understanding. Often people assume that video is face to face, as we are here static, but actually what we're after often is somebody to be able to position a camera where we can, observe them from a distance and see the whole person, and to understand that, and for the patient and consumer to understand why we need that and the importance and relevance of it. Yeah. Absolutely.
And things like mobile phones give you very small visual pictures, and no one really thinks about that, so you have to be further away, and patients constantly want to be very close. I think on a practical sense, technical wise, there's a lot of allied health clinicians are co-located in big offices with each other, and finding appropriate, quiet, private space to conduct telehealth remains a big challenge.
Amy, you were...
Oh, yes. Well, just to back up Pip and Miranda, really, especially with physiotherapy, we are in a big co-located office, so that is definitely a challenge as well. But what I'm finding working with clinicians who we're getting to come on that telehealth journey is that they're open and they want to give it a go, but it's a totally new set of clinical skills that they have to acquire and be able to learn along that process. So it's how we support them in gaining those clinical skills and building those to then be able to deliver telehealth to the standard where they feel it is of a face-to-face appointment. At the moment, there is a little bit of a mismatch there. And that's one of the big barriers we're coming up against, is them feeling like they can do a good job when delivering a video conference with a patient.
Right. Absolutely. Yeah, good point, Amy. Absolutely. Aoife, anything you want to add on to that?
I would echo that as well. And, even if we get clinicians to a point where they're comfortable using telehealth, now we're seeing, post-lockdown, we're seeing a decrease in uptake of telehealth and clinicians using uptake. So then how do we maintain those telehealth skills if we're not using it as frequently? So yeah, how do we kind of keep up skills and familiarity for our clinicians? And I think the other challenge that has struck us as well is just lack of technical support and having to figure out a lot of this on our own. And like not all of us being tech savvy or tech minded people, that being quite time consuming. I remember there was like 5 of us sitting in a room. How many speech therapists does it take to figure out a tech issue? But trying to figure out a way of doing voice therapy with patients, and having real issues with like the sound dampening, and you're asking patients to produce a loud voice, but when they do, the sound dampens down, so then you can't get an assessment of how their voice is sounding. So just been able to access some kind of tech support, I think, would be really helpful going forward, because that certainly presented itself as a bit of a challenge for us.
That Amazing. Do you know that had never even occurred to me in terms of the sound dampening? So it's a really, really key thing, that these are issues that we need to be sharing about, and certainly sharing possibly even some tech solutions around it. So we've had a number of questions crop up actually around tech issues. And interestingly enough, a couple of them address about tech checks. Now, I know that there are a couple of you out there, or certainly a few of you out there, who do have processes in place around tech checks. Do you want to talk us through what that means and how that works?
That will be me, I think. Yeah,
yeah,
you're one of us. So within the process or the solution that's been created for telehealth is the patient will get flagged in the triage process, or if they request an assessment, and then that is then sent through for a tech check appointment with our ICT department. So with us, Aoife, we do have some support and some technical stuff in the background there. The ICT department then links in with our patient and makes sure that they have an appropriate device, that their camera is right, that everything's working well, microphones, and they have the accessibility to everything that they need. That's either they spend half an hour troubleshooting with the patient if it's not quite right, and then if it's passed, fantastic, that then gets fed back to our administration staff, and then the appointment's locked in. So the idea behind that is it streamlines for the patient and also gives them a little bit of expectation as to what's going to happen in their clinical consult. So it preps them for that, as well as it reduces any technical issues that the clinician would have to deal with beforehand. So it's all smooth sailing.
Oh.
Yeah.
Has anybody else got a process for tech checking?
We haven't had a process at Southern DHB, but we have identified that there's certainly a need for it. And it's been a bit of a swings and roundabouts where that might live. Administration staff also, there's probably an opportunity to upskill and have some combined support there. But again, it's growing the skill set and the capacity for that to be done. It's certainly a barrier in terms of clinician time having to be dedicated to solving patients' IT problems.
Absolutely. Sharon, how about you guys?
So we don't have an IT team, but what we do is, for instance, one of our clinical groups who go out into the community, they pull patients from inside the hospital out to the community, and if they don't have anything to be able to use telehealth, then we will loan them an iPad and we will set them up with that prior to them leaving the hospital. So for that group of people, we do. For people who are coming through to outpatients, there's some information that's given out around the use of Zoom, and then there's the phone calls for the booking clerks to make sure that people can access it. We are looking to use the therapy assistants to help people learn before they go home from the inpatient wards. So for those who we're going to put out into just the community setting, who have the devices, we're giving them cheat sheets, if you like. But I agree, I mean, Wanganui, fabulous. You got an IT support team around you. That's pretty cool. It'd be nice to have that sort of people on tap, but I think for the bigger DHBs, that's probably problematic. But we're definitely looking to using digital post to get things out to the patients that way as well. Work in progress, I think.
Absolutely, yeah. I think it's a really interesting construct, because what we're doing is we're actually adding into the process of the need to contact, schedule, and flow through. And you kind of hope that if a tech check occurs, or the in essence whoever it's done by, that it occurs for this patient, that actually benefits this patient for any clinician that they're going to dial in with. So it's a kind of hopefully a one-stop shop with a bit of backup if required in the future. But it almost feels like there's a population digital literacy issue around this, and so it's something that I know that the ministry are aware of, but I think it's something that we need to start highlighting, is that actually how do we engage and ensure that that the processes are both integrated easily from the workflow perspective, but that we are meeting the needs on a consistent basis for our consumers around engagement. So just to finish off the technical perspective, Amy, I had a quick question about Teams linking into Webpass. I don't know if you know the technical perspective of that, but somebody's quite interested to hear a little bit more about that.
Technical aspect. The answer with my background as a physio is no, not particularly, but if they do want to get in touch with me, absolutely, and I can give them some more information when I talk to the ICT department. To add what you previously said, Becky, as well, the tech check that we do for a patient does span across all of the patient's appointments within the hospital, which is great. So that then feeds into Webpass and that's recorded there, and then that tech check lasts for anywhere between 3 to 6 months. We're still figuring out how long that needs to last for. Obviously, situations change, devices change, emails, phones change. But no, around the technical side as to how it exactly links into Webpass, I wouldn't know, sorry.
No, that's absolutely fine. We are clinicians first and foremost before technical experts, and I think that's a reasonable context to be in. So a couple more questions that we've had come through have been really great, and this one's a really good gnarly one. What do you all think about telehealth for the use of an initial diagnosis across the allied health professions?
My view would be that that's appropriate where you can elicit sufficient information to confidently make a good diagnosis and a treatment plan. And as with all consultations, being prepared to switch to the need for someone to come in person if you're not gaining that. But otherwise, I think the opportunity is there. I've not done many. Most have been follow-ups, just the nature of our work. But I have conducted some with another clinician at the other end, and just two where there hasn't been. And I think it works for the right circumstance.
Yeah, I would have to agree with Miranda. I think it is certainly possible, and it needs to be combined with some clinical reasoning as well as being patient-centred and around what the patient would like as well. So if there is the indication of doing that initial over a telehealth, and then you find out that it is no longer appropriate and you are needing a face-to-face appointment, having the flexibility to say, hey, and the skills to have that conversation, this is as far as we can go here, I need you to come in and see me. But if it works and the patient's happy and it's safe, why not?
I would echo that as well. I think if you're satisfied that you can glean the information that you need to make a diagnosis, then telehealth is a really good option. As an SLT profession within our team, we kind of decided that it would be rare that, say, with somebody who's presenting with dysphagia, it would be as easy to glean the information you would need to make an informed diagnosis with that cohort of patients. So we offer all of our outpatients telehealth or in-person appointments, with the exception of our dysphagic patients who get offered an initial face-to-face appointment. Having said that, though, we have had good success using telehealth to kind of screen some referrals where the info is a little bit dubious. So we might have it set up that a nurse will have an iPad in, say, a rest home to do a mealtime observation with an SLT sitting on the other end. So we can try and ascertain whether this is something that needs an SLT assessment, or if it's more like a feeding issue, like if it's positional or behavioral, in which case it wouldn't fall within our remit. So we've been kind of using it as a screening tool for our dysphagia patients, but for comprehensive assessments, we've kind of identified that really that needs to be an in-person to glean the information we would need to make an informed diagnosis.
Yeah, absolutely. Sharon?
Yeah, I echo everything that we say. I don't really see that we need to do a face-to-face for a diagnosis. And it's not necessarily that we should be using telehealth all the while. We could do initial assessments via telehealth, but if we get any red flags, that's when we bring them in, as we've all said. There's contraindications that we need to be aware of, so you have to be mindful of that. One of the things that the SLT group did, very similar to our colleague there, is around the rest home and the feeding and getting the nurses involved. And what that also did was that allowed the nurses to be able to work with their patients. So we would give the information with regards to feeding and swallowing, and then the nurses were empowered to actually give the patient what the patient needs, rather than us as therapists having to go into the rest homes. The nursing staff were just following through. So there's plus sides for telehealth for empowering other members of an IDT team that's not actually part of our DHB. And that was some really great learning that we got from the rest homes and the private hospitals as well, and they've continued with that process. But I agree, I don't think there's a problem with us using telehealth for a diagnosis. So long as we're aware of, if we think there's a problem, we bring the patient straight back in.
And I think it's really interesting. I think we've each spoken slightly from that lens of the need to. So often need drives service provision, you know, and COVID drove telehealth provision. But I think, and I can be very open about this, I'm a big advocate of choice in this situation, because I think if we were to try and approach telehealth from trying to craft principles and policies around cohorts of patients or contexts of access and things like that, it would just be an utter nightmare. But I think if we go, actually, it's just about choice within reason and clinical appropriateness, then, you know, we're going to be able to provide what's required to ensure that actually this is just another modality of providing a care and a service. So it's quite an interesting construct, because I think a number of our colleagues nationally are possibly just sort of thinking, you know, about cohorts and about where does this work and how can this work. But in fact, if we said, you know, it was a choice thing, it might have a different response.
I'll just chip in with a slightly, you know, a slightly different perspective rather than the clinical one and rather the social one. And so video conferencing essentially allows you almost like a home visit, which brings a lot of value to even an initial assessment. I remember a meat worker being able to grab the knife they use at work and show you literally on screen their work equipment, or things around the home, or their mobility in certain spaces. And on the other side of that, though, is some people are not in a place that they feel safe or dignified to welcome you into their home, and respecting that. So, you know, there's lots of things that contribute to that choice.
One of the other aspects moving away from allied health is, you know, we've got cardiac physiologists who are using apps within their work so that the patients aren't having to come in. They've got monitoring set up within the home so that the patients are able to do what they're required to do, but without actually having to come on site, which again reduces the stress for the patients. So it's another way, and I don't think that it should be seen as a new thing now. I think we should be embracing it and using it as business as usual, and bringing others along with us, you know, the doctors and the nurses along with us to embrace this way of working.
Amy, do you want to dive in?
Unmute first. Not at all. I just wanted to echo what Miranda said around, you know, it gives an openness into a patient's environment, but we do need to be aware of that, and allows for us to be more wano-centred. You know, for us, patients come into hospital and their wano isn't necessarily in the area. You know, all of a sudden they can click on a link and be there to support their family member and have that inclusiveness. And I think that's something that makes telehealth really powerful and quite special. And a valuable option in our toolbox to provide to patients.
Absolutely. Pip, did you want to add to that?
Just unmute myself. Yeah, no, I echo what everybody is saying. I was going to talk about our teledental project in the next question session, and so I can probably cover off some of those other aspects in what we're doing in teledental, around diagnosis, etc. So
cool. Okay. So is that about being a significant enabler?
Very much so.
Okay, well, I'll get you to kick us off. So the next question that I'm going to ask the panel is, telehealth has been a significant enabler of our services. What examples, where it's excelled expectations? So we've talked about some surprises, but Pip, kick us off about this dental service.
Yeah, so we've got a teledental project that's been happening. Now we're probably in about 2 years now, whereby we started off using it for general anaesthetic assessments, so for the patient's first FSA. So we're talking predominantly around paediatrics requiring a general anaesthetic. So most of those general anaesthetics are done in Whangarei Base Hospital or on the mobile surgical bus. realising Northland's geography, we've got lots of patients that are a long way from Whangarei Hospital, and to travel to Whangarei for an FSA for many is just not affordable. And also when you think about not only the affordability around cost and time, you know, for a 15-20 minute appointment is absolutely totally necessary. So we've been setting up therapy-led clinics in Kaitaia Hospital with a dentist sitting in Whangarei, and we have an intraoral camera that the therapist uses with the patient in the chair and with a caregiver present. And so the dentist can do the full diagnosis in Whangarei, and we can get that child onto the GA list pronto. So we're doing it at that end, and then the child will also require a GA recall assessment post-GA, and we're doing that as well for the patient. So they only have to come into the Kaitaia Hospital. So that was the beginning of the project. We have now extended it out to many of our other sites, including mobile sites as well, whereby the therapists have an intraoral camera available to them in the clinics. So they can make contact with a dentist at any time to get a second opinion or a diagnosis, and they can use that using the intraoral camera. So that's been a huge enabler for the service. We still send dentists to Kaitaia regularly, but it has meant that we're not sending dentists up there as often. And the therapists are just really enjoying the fact that the patients are in the chair and it is a therapy-led clinic. And of course, the whānau and the patients just think it's amazing that they can have this conversation with the dentist about a GA who's sitting in Whangarei.
Yeah, absolutely. Oh, that is just fantastic. Obviously, there's significant economic impact on that as well. And that through in terms of cost savings. Jonathan's asked a great question though for all of you, and it certainly relates to what you've just been talking about, Pip, there, is what clinical outcome measures and what have you got any patient experience measures evaluating the service?
Yes, we have. So we did an evaluation at the end of the first year of the project, hence why we're now trying to find a budget to find some more intraoral cameras to put across all of Northland and into all of the mobile facilities. So we've got lots of patient data. We've also done a cost benefit analysis as well. So there's huge savings not only to the DHB but also to the whānau that are not having to drive to Whangarei or 2 or 3 hours away to have an appointment. So also we have I guess the engagement with whānau and the patients has been huge, and so our patients that weren't engaging with the service, or we weren't engaging with I should say, or couldn't make appointments, it's just we hardly have any DNAs.
Wow.
And it's just all about access. Patients have been seen closer to home. So so it's been huge, and it's probably the best thing that we've actually ever done in oral health, I would say, in Northland for lots of years.
Yeah. Oh, that's brilliant, Pip. Oh, congratulations, fantastic work. Is anyone else using significantly the patient experience measures or clinical outcome measures in telehealth?
So we're using with the pilots that we've done, we've used patient experience, and we've got feedback from the patients, particularly around the lymphedema work that we did. And the feedback that we had was that it was better actually than coming into hospital, because people could actually still be at work and then have their appointment. And the Child, Women and Family Service, one of our key clinicians who's a physiotherapist, she created this mannequin for the families and the children. So the families were able to position the child, what she was doing with her mannequin. They had orthotics in on one Zoom. They would have the physio at one place and an OT at another place, and they work together as a team. So that's something that we're really pleased to see for the child, women and family and the paediatric team, because they're the area that, you know, if the kids have got to come in from school or mum and dad have got to take time off from work, being able to Zoom all together was just something that was really powerful from a patient and a whānau experience.
That sounds an amazing case study that I would love to see published around the mannequin use, because you can imagine I haven't heard much of that before, certainly, and it's an incredibly powerful tool, I would believe.
Really good tool.
Great. Miranda.
Some previous work with the paediatric dietitians and the paediatric endocrinologists I think they're working with. They'd done some patient experience and interviews. It was about 3 years ago. It's not published, but I think they're going to write it up, and it was all very positive. So these were patients from across the, you know, central Otago, who would otherwise have to travel several hundred kilometres, and being able to be seen locally. They were seen with an allied health or nursing staff at their end, but that was the earlier telehealth experiences and very positive. We now have patient surveys attached, I believe, to our telehealth links, so they're received by patients automatically, and we're getting some back, but I've not yet seen any of the collated information.
That's great to hear. Integration of evaluation is something that I'm really keen to see more of. I think that's a really powerful tool, is how can we actually almost advocate with Zoom or Teams to find to actually technically build in a tool that allows for that evaluation and feedback directly to the provider. So, you know, you'd sign off from a Zoom or a Skype or a Teams and it says, how was the quality of that call? Well, actually, I'd rather have a mini questionnaire pop up for my consumer, thank you very much, and then you can send me the information. So I think there's significant potential around that. We have 2 minutes left. Gosh, time has gone so quickly, and we've got unanswered questions. So apologies to everyone who hasn't had their questions answered. But I just want to whip around the panel and just say, right, what is your one priority for developing telehealth and consumer and clinician engagement? So where do you see telehealth going, and what is the priority for you in that place right now? So Aoife, I'm going to start with you.
I can only pick one. Oh.
Yeah, one.
I would love to see telehealth becoming like a normalized mode of healthcare delivery. So like I was saying before, we now offer all of our outpatients the option of either telehealth or in person, with the exception of our dysphagic patients. But interestingly, say with our voice caseload, like during COVID, there was an 85% uptake of telehealth. And then for June, July, there was 70% uptake. So patients who had began with telehealth opted to continue with telehealth, even though the option for a face-to-face was available at that time. And that has just steadily declined. So it's went from down to 35% in August, and now we're down to 5%. And I'd really like to examine why that is. Like, is it the way that we're kind of marketing it? Is it patient perceptions? I'd like to gather some more information about why clinicians maybe aren't as quick to offer telehealth, maybe why patients aren't as quick to take it up, and see how we can move forward with that.
Great, thank you, Aoife. Amy.
Wrong button. Absolutely what Aoife said, but for me, you know, there's a real importance around it being ProEquity, and that we're serving the whole of population with telehealth. You know, a stat that I read on Telehealth New Zealand the other day is that 20% of our population won't have access to this, and that's massive. So we need to make sure that we're thinking through that thought process moving forward.
Absolutely, absolutely brilliant. Miranda.
Two things, sorry. One is data. You can't do equity without data, and you don't know what your reach is. And second thing is administration support. We are so underpowered in allied health. Can't happen. We can't enable patients without that administration support. They're our front of house, not our back.
Thank you, Miranda. Great point. Pip.
Definitely equity, and also just having the resource to actually support telehealth within allied health.
Yeah, fantastic. Sharon.
Equity and business as usual, and making it the patient's choice, which is what we're doing, and populating it across where we can. But equity, I think, is the big thing.
Fantastic. Oh, wow, panel, thank you so much. And I can see from the numbers, nobody's dropped off, even in those last final minutes. So for all our audience, thank you so much for joining us. I hope you got as much out of it as I did, because I think there's been some really key points brought up today. I hope we may be able to do a version 2 at some point next year, and we can bring the panel back and add some new faces, but perhaps follow up on some of these topics to see how much further we've got. I believe there is significant potential across allied health, scientific and technical for telehealth. And like you say, you know, to have it as business as usual would be phenomenal to reach out across our population. So thank you so much, everybody. It has just been a joy to have you all on board. I can see lots of thank yous coming through in our chat space. So wonderful. Thank you so much. Take care.